I think we can start, Senator.
Okay. Well, with that, I'd like to call to order the Monday, October 21st meeting of the Katie Beckett Working Group. And I'll start. The first item is remarks by the chairs. It's great to see everybody. I will just say that Representative Gilchrist chaired the last meeting. I'm supposed to chair today. As you may be able to hear from my voice, I am battling a bit of a cold. So I may need to lean on her to take over at some point through here if I start to flag. Anyway, I will turn it over to Representative Gilchrist for some for some introductory remarks.
Great. Happy to jump in if you need some support, Senator. Good to see everyone. Loved our conversations at the first meeting, so really just looking forward to today's discussion.
Terrific. The first item of we have a new item on the agenda, which is public comment. And I'd like to ask to see if there are any members of the public who would like to speak to us. We did get a letter from the public. Chandra, would you be able and willing to read that to the members of the task force?
Sure. Would you like me to send it out? Would that be better? Because it is a pretty lengthy email.
Okay, yeah, that would be probably a better idea. I think that's right. Please send that out to the members of the task force. It was just a letter of testimony from a parent of a child who's been in the Katie Beckett waiver program who had some thoughts about the program, including questions of life expectancy and whatnot. She also was not informed about the program by her treating physician, and so had some thoughts that might inform what recommendations we might put out there. So I thought that was interesting, and we could send it out to members to read at your leisure. We would also invite other members of the public who have thoughts to contact us in advance of our next meeting. I think we would like to have comment from the public at subsequent meetings. So the next item is the approval of the meeting minutes from September 30th. We discovered shortly before this meeting that there was an error and the meeting minutes had not been sent out until I think just before the meeting. So in the interest of giving folks time to review the draft minutes, I'd suggest that we table this item and move to add it to the next meeting of the working group. Is there a
motion? Motion to accept.
Motion to table
it. Yeah.
Yeah. From Leslie. Yep. Is there a second?
I'll second.
Second by Representative Gilchrist. All in favor? Aye.
Aye.
Opposed?
Aye.
Okay. We will table it until the next meeting. Sorry about that. We at the last meeting talked about having the benefit of a medical ethicist to help guide our work. We have graciously been offered the services of one by the University of Connecticut Health Center. Would love to introduce our medical ethicist. Are you on?
I don't believe she's on yet, Senator. I apologize.
Oh, so much for that. Okay, well, we'll hold and hopefully get back to that later in the in the program. All right, so moving right along to item number 6 on the agenda, we did get a presentation from the Council of State Governments regarding TEFRA, the 1115 waiver, and the 1915C HCBS waiver. Do we have someone able to present that?
Yes, I'm here.
Hi, Sean. Thanks for joining us.
Absolutely. I'm going to try to share my screen here. If I can do this, let's see. All right. Let's see. Can everybody see that?
Yes.
And then I'm not sure how to. There we go. Okay. Well, good afternoon, everyone. I'm Sean Sloan. I'm a senior policy analyst at the Council of State Governments National Headquarters in Lexington. My focus in recent years has been on long-term care policy and Medicaid policy. I put together the agendas for the CSG Medicaid Academies that we host in DC every year. Representative Gilchrist is a veteran of those events, and last year served as one of our legislative co-hosts. This year, Representative Kevin Ryan, who is serving as the 2024 CSG National Chair, served as a co-host for our Medicaid Leadership Academy. I'm glad my colleagues on the CSG research team were able to put together some information that helped inform the first meeting of this working group a few weeks ago. I apologize I was not able to join you for that meeting. I was actually in Washington, D.C. that day for a meeting hosted by the Johns Hopkins University Bloomberg School of Public Health. Some folks there are working to put together a state scorecard for Medicaid HCBS programs that would be similar to the scorecard that AARP puts out on LTSS programs. The other folks around the table were from places like KFF, MACPAC, CMS, AARP, NCOA, and the SCAN Foundation. The discussion, which focused largely on the data elements that they hope to incorporate into the new scorecard, significantly highlighted waiting lists in a number of ways. Both MACPAC and KFF have tracked waitlist data in recent years. A couple of folks mentioned that sometimes facilities can have visible or invisible waiting lists. Moreover, there has been a shift in nomenclature in some states to use terms like registry or referral list instead of wait list to manage future reporting requirements, which may complicate identifying individuals on wait lists. The final Medicaid access rule, as I'm sure you know, will require states to report waiting list data by 2027. So thanks to the magic of YouTube, I was able to view the recording of the September 30th meeting to provide some context for today's hearing, and I took some notes on some of the issues that you all were interested in exploring. Representative Gilchrist also shared some additional questions that you all may be looking to address. I've consulted a number of resources that appear relevant in answering those questions, and I've reached out to a number of my contacts in the Medicaid and public policy worlds in recent days for their input as well. So I hope to walk through some of that over the next few minutes here. As you all know, and as you saw from the information shared by our research team, states administer Katie Beckett services under several different types of configurations. And I know that one of the things the working group is interested in is the pros and cons of each model, and also what each one requires with regards to the Katie Beckett population. Since 1982, states have been able to implement Katie Beckett programs through either the Tax Equity and Fiscal Responsibility Act of 1982, or TEFRA, state plan option, or through Medicaid waivers. Overall, 44 states have Katie Beckett coverage. 17 states offer coverage through the state plan. 22 states offer coverage through a waiver, and 5 states have both waiver and state plan options. Waivers can provide states more flexibility to offer additional benefits, including family support, care coordination, specialized equipment, medical supplies, respite care, medical daycare, and home or vehicle modifications. The TEFRA option, as you know, offers the main advantage that the program must serve all eligible children who apply, and there can be no waiting list. The TEFRA option also determines eligibility based only on the child's income and resources, and the parent's income does not factor in. The main disadvantage of the TEFRA option is that it just extends regular Medicaid state plan services to children and doesn't offer the opportunity to provide those additional benefits and services through the program directly that we see under the waiver models, such as respite care and home or vehicle modifications. The other potential disadvantage is, of course, the cost of enrolling all children with all types of disabilities. And some states have chosen not to offer those voluntary programs for precisely that reason. 7 states have their Katie Beckett programs all or in part through an 1115 waiver, which allows them the option to create unique programs to meet the needs of people with disabilities, or in the case of an 1115 demonstration waiver, to replace their Medicaid program entirely. So these programs can have a smaller footprint, similar to what those states might have under a TEFRA or 1915C waiver, as in Arkansas, or they can be incorporated into 1115 demonstrations to reform an entire state's Medicaid delivery system. For example, Arizona's healthcare cost containment system and New Jersey's Family Care 1115 comprehensive demonstration. The main advantage of an 1115 waiver that is well designed and comprehensive, according to kidswaivers.org, is that you can streamline the process of eligibility and services by combining programs together to serve multiple populations. The primary disadvantage is that in 1115 allows states to waive certain other Medicaid rules, so there may be fewer protections for individuals in these programs, and they may serve to restrict services or eligibility. Most waivers currently in use for Katie Beckett programs are 1915C HCBS waivers. These provide both Medicaid coverage and additional services to specific disability populations. The main advantage of 1915C waivers is that they provide extra services to help people with disabilities live at home, such as respite, home or vehicle modifications, training, and specialized medical equipment. The primary disadvantage of 1915C waivers, as you know, is that they are not entitlements, which means they can have waiting lists. Many programs with these waivers have waiting lists that are more than 3 years long. There are also states that offer Katie Beckett services or have offered them in the past through either a state-based program or through 1915I, 1915J, or 1915K waivers. State-based programs like Pennsylvania's PH95 program seek to mimic the TEFRA option by either expanding eligibility or restricting it somewhat. Some provide full access to Medicaid, while others only provide certain services. Some states use those other waiver authorities I mentioned to offer home and community-based services for children already enrolled in Medicaid through the regular state Medicaid plan. Idaho is an example of a state that at one time used a 1915I waiver that provided family education, habilitative supports, respite, community support services, financial management services, support for broker services, crisis intervention, family training, habilitative intervention, interdisciplinary training, and therapeutic consultation services to individuals with autism, intellectual disabilities, or developmental disabilities up through age 17. The state can restrict the program to individuals of certain ages or with particular diagnoses, but there cannot be waiting lists under a 1915I program. The Idaho waiver was designed such that access to Medicaid for children was provided through a Katie Beckett TEFRA program, and HCBS was offered through the state plan. California's in-home supportive services program is made possible through a 1915J waiver that allows those already enrolled in Medicaid to access personal care services that they self-direct, and allows the state to pay parents of minors for providing personal care services. Many programs also have 1915K waivers that allow them to provide personal assistance and other in-home support through the regular state plan for those already enrolled in Medicaid without waiting lists. These are going to be your community first choice option states, including California, Maryland, Montana, Oregon, and Texas. This provides a 6 percentage point increase in federal matching payments to states for service expenditures related to this option. From listening to the hearing from the 30th and from the list of questions that Representative Gilchrist sent me, I know that one of the things you all were interested in is kind of why different states chose different models or configurations for their Katie Beckett program. And from what I've been able to glean, it was likely much like what Molly Cole talked about on the 30th with regards to why Connecticut went the direction that it did. The 1915C model may have been the most expeditious path at the time to being able to support a Katie Beckett program, even though the TEFRA option may have had more advantages, including no waiting lists or rationing of services. Eventually, as other states began to explore offering Katie Beckett services, the TEFRA process was becoming easier to navigate and an easier option to select. I think the other answer is something that we hear repeated at all of our CSG Medicaid academies, and something that I've probably heard at every Medicaid-related meeting that I've ever been to, which is, if you've seen one state Medicaid program, you've seen one state Medicaid program. If you peruse the state waivers list on Medicaid.gov, which you see here, you'll see states with multiple waivers covering different populations. You'll see waivers that were once in operation that have been terminated since. You'll see states that have moved toward those more comprehensive programmatic reforms that address multiple populations. State Medicaid programs are constantly evolving, and policymakers are exploring different ways to serve their citizens through this program. And CMS evolves too in what they're hoping to emphasize and work with states to achieve. It can be a challenge, certainly, for a state to shift gears to a different model, and those negotiations with CMS can be complex and take a long time to win approval of a new waiver and so forth. But it's something that numerous states have done. It's something, and if something's not working, it can be something worth exploring, certainly. The other thing that Molly Cole talked about at the September 30th meeting that I was interested in, someone asked her to identify some TEFRA states that are models to look at in terms of serving the Katie Beckett population. And the 3 states that she mentioned were Minnesota, Rhode Island, and Wisconsin. I reached out to some folks that I've worked with in Wisconsin, and if you look at their Katie Beckett program, children who qualify receive a Medicaid insurance card, which can be used to pay for health-related services and equipment. And Katie Beckett Medicaid can work along or together with private insurance to cover services and equipment. But the Katie Beckett program in Wisconsin is just one part of a comprehensive children's services program in the state. This is just the top of this document that I have pasted in here. But if you click on that hyperlink title at the top, you can read the whole thing. But this is a long list of services offered through Wisconsin Medicaid on the left, including through Katie Beckett and Badger Care Plus. In the middle, the Children's Long-Term Support Program and the Children's Community Options Program. And on the right, some exclusive supplementary CCOP services. Eligible children can be enrolled in one or more of these programs, depending on their needs and the needs of their families. So this list is something that you might want to check out as you contemplate how other states are looking at the full universe of options to address the needs of children. So that is essentially what I have for you right now. I did reach out to a number of other folks who I am still hoping to hear back from, but have not yet, including friends at KFF and NASD's, the Developmental Disability Services Directors Group, and Advancing States as well. if I do receive any additional information or resources from them, I will certainly pass them along. One of the other things that interested me from that first meeting was the discussion of how waiting lists are such an imperfect and imprecise measure of unmet demand. They're also not necessarily comparable across states or over time. I know that KFF has added a question on their surveys recently that they're asking states to ask them to report the number of people who were on interest lists for HCBS as well as waiting lists. So as you contemplate perhaps making these services more widely available, I know that those numbers will be important to consider in addition to what the universe of program recipients looks like in TEFRA states, for instance. So anyway, I continue to reach out to various folks and continue this fact-finding mission. Just before this meeting, I did hear back from Alice Burns at KFF, who's one of the top experts in the country, and she told me that they are working on a national level analysis of the kinds of issues that we're talking about today. She's not sure they'll be able to have state level data when they release that, but that is something to look out for. In the meantime, you can shoot me an email with any additional questions that I can try to get an answer to for you. Thanks so much, Senator Lester and Representative Gilchrist and members of the working group.
Sean, thank you so much for that wealth of information. And I know many of us were furiously trying to take notes and keep up. And thank you for sharing those slides as well to help us make sense of it. Do you have a few minutes to answer any questions from members of the task force?
Absolutely. I can certainly try.
Okay. Well, one, I was really interested in hearing about the state that you mentioned, and I'll have to go back and review which one, which separated HCBS from regular Medicaid, because it does seem like the majority of interest in the Katie Beckett program in Connecticut is for HCBS. And when they do that, does that mean that they don't have a waiting list for HCBS services? Or is it the reverse?
You know, I think there are states that have that have both and but you know under the Medicaid I guess they would not have a waiting list unless they have 1915C. That would be the only one where they would have a waiting list.
And is there any us choosing between these different implementation models? It doesn't seem that there's any impact on reimbursement rate, that they're all pretty much reimbursed at the same rate. Is that accurate? Is that what do you have any sense on in terms of fiscal impact on states, anything we should be considering?
That is not something that I identified in this research, but I could certainly look into that for you.
Right. Are there questions from other members of the task force?
Here's my question, and thank you so much, Sean, for this presentation and for pulling together all this information. It's very helpful. My question might be more directed at DSS. With regards to the fact that we're 1915C, what additional services do we provide under our Katie Beckett program that aren't covered under straightforward Medicaid?
Yeah, so I was hoping you guys, right. I'm glad you actually caught that, Rep. Gilchrist. So technically, what we're offering is we're not offering enhanced HCBS services on top of state plan services in the Katie Beckett waiver. What we offer is a set of individuals under 18 with a disability who wouldn't otherwise be eligible for Medicaid to have access to Medicaid through the waiver. We don't actually have additional enhanced services. We have a case management function that is very thin. It's every 6 months they touch base with a registered nurse case manager. But really what we're waiving is Connecticut's rules of eligibility to allow them access to Connecticut Medicaid. which is a little different in how the presentation went in other states. We don't have those other array of waiver services that you might find in traditional 1915Cs. Our Katie Beckett waiver really is access to Medicaid instead of access to enhanced HCBS services.
Thank you. So then would it be fair to say that under the way we have it, under our 1915C, it's the same as TEFRA? Because TEFRA gives access to folks who otherwise wouldn't qualify for Medicaid.
Yeah, so I guess for purposes of the recording and for my, I'm going to put an asterisk on this without having a full understanding of TEFRA. What we are allowing is Connecticut, based on our 209B status, cannot be a TEFRA state, but we waived that children with disabilities under the 18 who are not traditionally covered can be then covered through the 1915C mechanism. So similar, I guess, in look and feel, but not all aspects of TEFRA, because I don't know all of the components, but we are getting it, an individual who typically would not be eligible, we are getting them in the door through eligibility in a different way.
And then one final question, and this might be back for Sean, unless, with TEFRA, okay, I'm now going to forget that phrase, but it's that phrase that people's private, and it's the payment of last resort. So would Medicaid under TEFRA still be the payment of last resort? So if folks have private insurance, would that cover their children before the Medicaid kicks in?
I don't know the answer to that.
Okay. That's just then something I'd love us all to kind of figure out, because I'm just trying to get at, our conversations from last time, and I'm excited to hear like how many folk, we discussed how there's a lot of families who it appears are receiving the Katie Beckett here in Connecticut, but actually aren't utilizing it. And so I'm just wondering if at some point we decide to go the TEFRA model, it really doesn't potentially change anything, since it'd be the payer of last resort. But I guess we need to know that. I don't know if that's the case. So thank you. That's it. I'll stop there, Chair. Thank you, Senator.
Can I ask a question? It's Leslie. Would a 1915 I or J work here?
So I'll take that one if you want, if that's okay. So if you go to that slide, so we have a 1915K. We have a 1915K. And in our report later in the afternoon, we're reporting out on how we utilize the 1915K in relation to the Katie Beckett waiver individuals. A 1915J is another version of personal care services for individuals on the Medicaid program. Again, our Katie Beckett waiver participants have access to personal care attendants through the 1915K, and they have the home health aid benefit through the state plan option as well. So expanding that, what I think the purpose of what we're looking for in Connecticut is broader access for individuals that have a disability under the age of 18, which the only way to be deemed outside of your family without having your family otherwise qualifying is through the Katie Beckett waiver. Really, the services when you get in the door, Connecticut has a robust array of services that are available to individuals. It's how you get in the door. These children are getting in the door through the wait-listed and limited capacity of the Katie Beckett waiver, where there is no other door for them unless their parents qualify for Medicaid. So I think, Leslie, once they're in the door, there are services available to them. Even if Connecticut expanded their 1915I or 1915J, it doesn't grant access to those children because Connecticut doesn't consider them discrete households. Okay. If that was clear.
Yeah, it makes sense. Yeah.
Okay.
But I think, sort of following up on Representative Gilchrist's question, my idea, the question about separating out HCBS from regular Medicaid, I think is maybe helpful, but maybe not, because, if the folks who are not otherwise eligible for Medicaid are they're only getting these services because of the Katie Beckett waiver, presumably they have insurance through, or many of them will have insurance through some other vehicle. And so, assuming that the insurance, it picks up the first dollar for other healthcare services, really the main, yes, there's some other services like non-emergency medical that may not be covered by private insurance, but the main benefit that I think most families would get would be HCBS services, which are not covered by insurance. So that would be the main benefit of the program. But I don't know if there's significant uptake of other services, and maybe, maybe we're wrong, and that and that Medicaid is picking up the first dollar, which would be not what we're intending to do. But assuming it's last dollar, I would think that the HCBS service is really the key thing here. Molly, you have question? You have a question?
I have a couple of comments, and I truly don't know if anybody can answer this, but Christine, I'm sort of directing it to you. Because we're a 209B state and that prohibits going after TEFRA, is there any sense of how complicated it is to not be a 209B state? Because there used to be more than 12. I think we're one of 12 now.
Yeah.
And I just wonder is there a way to move on from that so that we could have a TEFRA waiver?
Yeah, so that's absolutely outside my scope of authority or decision making. But I do think I know Nick Vendito's on, who's been a long-term DSS staffer and currently at OPM. This would be impactful to, I think, the entire Medicaid program, not just HCBS and not just Katie Beckett. So it has a very broad sweeping implications. Our 209B state is more restrictive than TEFRA states, and that is a very meaningful in Connecticut, I'm sure. So Nick, I don't know if there's information on our past explorations on this, or if you have anything to share.
No, I think you covered it, Christine. I think that gets into the impact of that would be across the program. That's a much bigger programmatic change. I mean, I can see what things we've done in the past regarding the ins and outs of the 209B designation, but I mean, that would impact a lot more than Katie Beckett to try to move off of that.
The 209B designation, just so everyone understands, is in contrast to states that are SSI states. So in those states, if you qualify for SSI, you're automatically enrolled in Medicaid. So the 209B just allows us to, in certain circumstances, apply a more restrictive criteria.
Correct.
Right. Which
and just one, Go
I
ahead.
was just going to say, which would mean that there would definitely be budget implications in moving away from that. But
there would. And then just a comment, Senator Lesser, with the insurance coverage, the other big difference when you're on a Katie Beckett waiver and you have private insurance is that your providers have to accept whatever insurance pays as full and complete payment. They can't balance bill you. So there's a level of other protection that's there, even if Medicaid isn't paying the bill. So it does really offer some good safeguards, I think, for families.
So the private insurance would be paying the bill, but the Medicaid protections around balance billing would apply?
Correct. So I can, that was very common for me, that my, insurance paid a portion of a bill, but it might not pay the entire bill. However, the provider couldn't balance bill us because we were protected by Medicaid.
Right.
Interesting. Other questions for Sean while we've got him? Well, thank you very much. This has been hugely helpful. Thank you to CSG for all your work, and we really appreciate you being a resource for the legislature and for this task force.
Thanks so much.
Okay, so next up on the agenda, we do have a response. We had a bunch of questions for DSS, and we did get written responses from them, and we're just hoping that DSS could walk us through the responses. Dave, are you here to do that, or Christine?
I think Dave would probably have me do it. I don't know if Dave is on. Dave?
I think so too, Chris.
Okay, I'm happy to take it. I'm happy to take it. Just, do you want me to share the document? Is that how this works? Let me screen share. Okay, it's this document. Okay, hopefully you're seeing my Katie Beckett working group one pager. Yes.
Yep.
Okay. So we took the majority of the questions that were asked and tried to kind of distill them down into clean responses for you that I could walk through. And there's some things that we're still working on queries on, with what we call our data warehouse queries, that we're still trying to kind of drill down to some very more specifics that you asked for that we weren't able to produce this meeting, but we'll share the next meeting. So the first question we were asked was, does DSS have data on the number of people actively on a daily or monthly basis using the state plan waiver services? And is there any fiscal data on who is on the waiver using private insurance versus Medicaid? So some of these things are hard to really pull out of our data warehouse, but we were able to get some approximations where approximately 30% of the waiver participants had Medicaid claims partially paid through other insurance. So to the conversation we were just having previously, that Medicaid was the second payer, and that there was another private insurance that was a primary payer. And this supports that some of our participants had primary insurance and used Medicaid as a backup. And we're trying to get down to the more granular level, where you kind of wanted usage by waiver participant. So that gets a little hinky in our system, and we want to make sure that we're really giving you valid and important, accurate data. So we've taken some time and still need to get back to you on that. And also the way our data works is it's kind of snapshot. We did a calendar year, which means people can come on and off the waiver for different reasons. They might have moved, they might have aged out, they may have qualified for Medicaid without needing the waiver. So we have what's called an unduplicated recipient count, which at any given point throughout the calendar year, if you were on the waiver, you're going to be counted in this report. So that's the 375 that received care management. And just to orient back to last conversation, care management is our only waiver service. Katie Beckett does not have enhanced additional waiver services. They have care management that gets them through the door, and then they access our state plan services. So Medicaid paid around $3 million of inpatient hospital costs for individuals that were served on the waiver. We had about 300,000 go out to physicians, where we were billed as the secondary or the primary insurance for physicians. We had outpatient clinic visits by 220 recipients, lab and x-ray bills, pharmacy bills, home health, which is could be skilled nursing, PT, OT, or home health aides that come out to the home. That was around 4.4 million for 71 unique recipients. Community First Choice, this is where I had talked to you about last week, how a few weeks ago, last meeting, how a number of our families have started engaging in Community First Choice, which is that state plan option to have PCAs in the home. So individuals in the home to help with care. So we have about 121 individuals in calendar year 23 that had some level of a care plan in Community First Choice. So average monthly cost is around $1,800. Average cost per user, $20,000. Again, these are estimates and they're around utilization. Their care plans may have been authorized for greater amounts, but they may not have been fully staffed, or they might have come on mid-year. So these are rough estimates for the calendar year of 2023. So that was another 2.5 million that went to in-home care. So when we talk about Katie Beckett waiver may not have enhanced HCBS, but it gets you access to state plan home and community-based services like Community First Choice. Other is a myriad of things. We haven't really been, those are just other Medicaid costs. We don't have that drilled down, but this is a federal report that we're obligated to send. And this is the kind of the buckets that the feds ask us to break them down into. So overall, the Medicaid costs came down in calendar year around $19 million, with an average of $4,600 monthly. Currently, date and time, there's 91 Katie Beckett waiver participants that are utilizing CFC. So again, that's that fluctuation, people coming in and out of services on and off the waiver. And those were the primary questions you had asked us. You had asked us to look at primary insurance versus Medicaid as the primary payer, the breakdown of the global utilization, which I don't have again at the member level. Like I can't say 10 members used $2,000 or less, 22 members used 10,000 to 30,000. We don't have that yet. Our systems are not that sophisticated for me to be able to pull those queries that quickly. But this is kind of the overview, the snapshot of Medicaid spending for the individuals that are on the waiver. The other questions we were asked were around the TEFRA, which I don't want to get into since we just talked about it. And it's really kind of a non-starter for Connecticut now until OPM or the department decides to move forward with TEFRA. That is not for us as the waiver unit to decide. So we do have ct.gov primary source information that we took the bullets from below that is an active link for anyone that wants to read through that about Connecticut. So I can take questions on this if anyone has any questions. I hope that answered the outstanding questions. I don't know if I missed anything.
Yeah, thank you for that. It looks like, so I guess my comments earlier were mistaken that obviously if the average cost per person, as I'm looking at your chart, is $51,000 per year, and the cost of Community First Choice is only, well, first, I guess, what's the difference between Community First Choice and home health? I see those as two different items. Can you just work?
Yeah, sure. So home health is through a registered home health agency where you have an RN and LPNs that come out to the house. There's a plan of care, and a home health aide comes out to help with bathing and dressing, eating, toileting, any of those needs from a home health agency. And they're provided oversight from a nurse typically. And there are some restrictions on what they're allowed to do, but they're home health aides. Community First Choice is a different delivery mechanism, and it's kind of a paradigm shift from home health aides to self-directed personal care attendants. So the individual hires people that they choose to hire. It could be family members, it could be a neighbor, it could be someone from, their doctor's office that they love, that they want to bring into their home. Like, you can choose who you hire, and then you set the schedule, and you are the employer of record. So it's a complicated program, Community First Choice, but it provides employer authority for the individual to set their schedule and determine who they hire. In home health, you're registered with an agency. An RN sets you're going to get 2 hours a day from this person to help you with X, and it's an agency-based model. So it's just it's a delivery mechanism that differs, and some people choose home health. And then there's other services under home health, which is PT, OT, speech. You may have catheter care that's necessary. You may have G-tube care and that sort of stuff. And that all comes from registered nurses at the home health agency.
Okay. And this is a sort of question I asked, I think, Sean earlier. In terms of reimbursement rates, I know that some pediatric services or pediatric Medicaid populations are reimbursed at a 90% rate, and others are at a lower rate. Is there a standard rate for the Katie Beckett? Is it 50%? Is it 90%? Where is that?
So, well, all of our waivers are 50%, but I'm going to defer to Nick, my fiscal guy, to say the specifics about that.
Yeah, the match rate, federal match rate through Medicaid for those waiver services is 50%. The only thing on this list that would receive a slightly increased federal match is Community First Choice, which gets 56%, has that added 6% that I think Sean mentioned in his slides. The other waiver services would all be matched at a normal 50-50.
Okay. And would there be any if we were to find some sort of way to do this, would it be possible to create some sort of standalone Katie Beckett Light program around care management and Community First Choice? Is that something that would be desirable for families who are waiting to get the more robust level of services outlined above, assuming that most of the folks will have insurance through some other source? Is that something that would be feasible administratively if it were a good, if we decided it were a good policy?
I defer to Christine on that. I think
I thought it was a family question. I thought he was asking the parents on the
Oh,
call.
sorry.
I'm actually asking both, but start with the parents. If it's a bad policy, then we don't need it. But I'm just sort of thinking, for all those folks who are in line right now, would seeing that a little less than, about a little more than a third of the cost of the programs for the CFC as a way to lower costs, to provide that extra personal care attendant support, but without providing the pharmacy, the physician, the inpatient hospital coverage. Is that something that folks would see as a significant benefit, or should we be looking to hold out to try to make sure that all those services are available to all the parents and families who need them?
Well, it would seem to me that if you have a child with medical complexity, CFC, for a lot of reasons, wouldn't be your choice, because if you really need services out of an agency, if you need a skills level of care, if you need some of those more high cost expenses, CFC isn't going to cut it for you. Training your own staff to be in the home is great if it's some basic care, but when it comes to a skilled level, which a lot of the kids, it would be interesting to look at the waiting list and to see how many of those kids have a degree of medical complexity that would sort of rule out using CFC versus those that are in. So I think it's a tough question to answer without getting better detail about who's on the list.
Yeah, and CFC is fairly restrictive because it is a state plan option. You have to already be otherwise Medicaid eligible, which means you need Katie Beckett to get through the door. It's a very chicken and egg situation with these state plan services. Katie Beckett could maybe, the individuals that are waiting might benefit from state plan services, but you need to be on the waiver to receive state plan services. And then our state plan services are restricted for people that are already eligible. We can't create an eligibility group for community first choice. You have to already be found eligible. So it is a little sticky. And Molly, I do hear you. It's really the intensive home health services, which I was surprised that only 71 individuals were accessing. So that's why I really want to do a deeper dive in our query, because my guess is that number is higher. We may have carved out, we may have taken complex nursing out of this query. It might be how it's set up for CMS, which might not be how it needs to be read for us. So I'm going to take this back to our fiscal team. That 71 is questionable right now to me, just knowing the complexity of the individuals that we serve. But yeah, I do think we are around $51,000, in utilization.
Just a point of clarity.
Go ahead. Sorry. No, I was just saying that's because of that marriage between private insurance and Medicaid. We are not paying the entire medical cost of a number of these individuals. We are paying as what they call it, third-party liability, or there's someone else involved in the care. We are picking up a percentage of that care.
In terms of medical equipment, such as wheelchairs, walkers, and all the plethora of equipment that is needed for someone with complex healthcare needs, what bucket does that fall into in these categories?
That might be an other. So I don't see DME. So that would be durable medical equipment. And that could potentially be our other, which when we do our deeper dive, especially since some of you asked about like kind of those covered costs, that would be my assumption is that's another.
Thank you.
And I just wanted to add one other thing. As being recently putting on the wait list for Community First Choice, I did have my intake done with them and I was granted hours, but again, it comes with, another wait list. So even though it would have been a great idea to maybe if we could have, but we can't anyway, presumptively put somebody on that while they were waiting, it's still another wait list. So it's not even going to be, that much beneficial. However, the program, when you're a parent with a complex medical child, sometimes the family is the best caregiver to help take care of your child. So it is a viable option, and it is a good resource for parents with children because sometimes it's hard to trust somebody from the outside to care for your medically complex child. So it is a great program. And we're going to totally take advantage of it when the wait list comes our way and we're eligible. to start the program. But I mean, we were found eligible, but we still have to wait 6 months in order for it to get processed. So again, there's lots of wait lists for everything, which tends to be the norm once you get into the Medicaid stream.
Take your name, because I don't know why you were told that there's a wait list. So I need to talk to you about that, because that might be, there isn't. So I'm going to talk to you offline. So
I'm so
that's
sorry
okay.
for the information that I was given.
No, listen, that's one of my programs too. So I'm happy to help and try to see where the disconnect is on what's being shared or the language that's being told to families. So I'm going to talk to you offline if that's okay.
That's fabulous. But however, it is a great opportunity for parents who may be reluctant to give over their care to somebody who they don't know through like an agency. It gives families an opportunity to have somebody who they trust to give care to their significantly challenging situations where they have children with complex medical needs. So I love the program. So thank you.
Okay.
I just wanted to kind of, I think I'm following this chart, but just wanted to talk through. So the care management, is there a total of 375 people on the Katie Beckett currently? So everyone on Katie Beckett is automatically like part of the care management.
Okay, so this was right in the point in time of 2023, 375 people between January and December were served by the waiver. That wasn't our final count. It's just as people roll off, new people come on. So if 10 people rolled off, 10 people came on, that adds a plus 10 for that calendar year. But really, we maintain, Paul, what is our current number? It's not 375, it's lower. Are we at
328?
328. So I was talking to our nurse about some of these numbers. You know, individuals come off of the Katie Beckett waiver for a number of reasons, right? So they age out, they're eligible for another HCBS package that might have more robust services once they hit 22. They might otherwise be eligible for Medicaid and don't need to be taking a waiver spot for Medicaid because they have reached a disability determination. They're 18, their family is now on Medicaid. People move, right? So people just from natural growth, people move out of state. So we move the wait list over each month. We're always looking at capacity to see if we could add people. So that's why there's 375 for the calendar year of 2023, but our wait list count is actually 328?
Correct.
Okay.
Okay. Thank you. And then with these unduplicated recipients, could someone of that 289 folks who got pharmacy, I'm just using this as an example, they could also be part of the outpatient number?
Of course, yes.
Okay.
Yeah, these could all be the same people.
Okay. Is there a way to pull it without, of course, giving anyone's, and maybe not, but without giving anyone's identifying information, to see what the breakdown is in spending per person on? Okay.
We're trying to do that. That's what isn't prepared for today. We really want to make sure we're going to run and rerun the queries and run it by a few people. It's just, it's a very hard to drill down to Medicaid data at the individual level and then have an accurate reporting to then match back to what you believe is the universe of like these numbers. It takes a long time for us to do, and we don't really have a huge analytical team to support us with that. We're using our fiscal team and Paul and some other people. So we hope to have that for you for the next meeting.
Awesome. Thank you. Thank you very much. This is very helpful.
Yep.
Thank you. Are there other questions for our DSS team or for Christine?
Just in the interest of being one of the representatives for a child with terminal illness, for folks that have a child with terminal illness, one of the things that we are often exploring is around like home hospice care. I'm curious, within the home health or any of the other categories, is that a service that is covered within the current confines of the program?
Yeah, so I don't have all the details on the Medicaid hospice service, but there is a hospice service within Medicaid. So if you are otherwise eligible for the state plan program, there is a hospice component. I don't have all the details. That is not something managed out of my area, but it is something that we have.
Thank you.
I just had a.
And I'm sorry, I'll turn it over to Emily in a second, but just following up, just do you know if the inpatient hospital does that include hospice services when we're looking at that, or is that some sort of other, is that captured under other, or do we not know that?
I can research our hospice benefit and get back to the group. I don't want to misspeak on the benefit. I'm not certain.
Sorry about that, Emily. It's all yours.
No, I apologize. I was going to ask the same question if it requires something beforehand. And my other question was, as a physician who takes care of a lot of children with rare diseases, the point someone else had just made about families who really want to do their own care within their home. I know you spoke to that from DSS's point of view, but is there any further work on expanding that? Because I know many of the families of my patients wish that.
Are you asking if DSS is doing anything beyond?
Just not necessarily you, but even other groups. Just because that is a big thing that's brought up at visits with me. Just more support for the family to be able to do the care themselves.
Yeah, so what they call self-directed or consumer-directed and choice services is a tenet of CMS and a lot of the HCBS services. So when possible, if a program can select the option to have self-directed, we certainly would like to support that. So we have, DDS recently just expanded some of their services to allow parents and guardians to provide some of the paid care. Connecticut, most of our programs don't allow legally liable adults, but we allow all extensions of family. So siblings, aunts, uncles, cousins, most of our programs have some component or some service that could be used at that level in our HCBS space. It's not in the more regulated space. So when you're talking about home health, which is licensed under DPH and has registered nurses and that licensure, that medical model, that's not able to do it. But in the long-term services and supports vein of DSS, we're certainly in support of self-direction and consumer employer-directed choice. It is because CMS is acknowledging, also there's a workforce demand, right? So, who better to hire than those that will love and support your individual and will show up to shift and instead of trying when there's a workforce shortage in HCBS, because we have just expanded people's reliance on community-based services versus institutional settings, and the workforce hasn't kept up. So it's a complicated dance, but we do have it. There's a lot of regulation and a lot of control for it, but we do understand people's desire to hire family.
Thank you, Christine.
Anybody else? Okay. Well, thank you, Christine, for that. And if you could get back to us with those follow-ups, that would be super helpful. Okay. So moving right along to item 8 on the agenda, we received an OLR report on the Katie Beckett Waiver Program in Minnesota, Wisconsin, and Rhode Island. Is there someone on from the Office of Legislative Research?
So actually, I'll give a quick update. So they did provide us with some initial information that we're happy to share with folks, but they needed some more time. They're reaching out to each state individually. And so we'll actually have a fuller report next meeting.
Okay. So the next item of business is the announcement of the date and time of the next meeting. And we can't do 3 weeks from today because that is Veterans Day. But we are looking at doing the following day, November 12th, 11:30 to 1. And that would be Zoom only as well. Is there anything, obviously the folks are going to have different schedules. Are there any, before we set that, is there any reason why we should not consider that to be the time for the next meeting?
If that's the set time, unfortunately, I will not be able to join because of work conflicts.
I'm not critical, but I will not be here either. Paul can certainly be here as in my place, but I'm off on the 12th.
Okay.
Sorry.
All right. Well, we will miss you both. I think we will go forward with it at least as the tentative time at this point. And if something changes, we'll have Chandra send it out to the group with as much notice as practicable. Any before we adjourn, any other comments from members of the committee for the good of the order? Anything else that you would like us to consider at our next task force meeting?
No, I would just then echo, yeah, if anyone, if there's anything coming to mind that you think would be helpful, more information, presentations, please either share that now or feel free to email Chandra with those thoughts, and then we're happy to try and coordinate the presentation.
Okay, and we still have not received the ethicist has not joined us. Doesn't look like she has.
That's correct.
Well, that's disappointing. All right. Well, we will circle back with our friends at UConn and see what we can. And but meanwhile, yes, if you have ideas as well about other things you'd like, just please reach out to Chandra, and we'll try to make sure that we can consider that for the next meeting. All right. Well, thank you everybody for your participation today. Take care, and hope everyone has a great few weeks.